now move on to understanding the use of bits of physics, math, cells, and dendritic cells, right? So let's first look at our eosinophils now. The eosinophil babies are basically they kill worms. So they are basically the worm killers. Their main job is to kill parasites, especially the helminths. The helminths are the worms, right? They appear like this bioluminescence, which looks like sunglasses. So imagine these look like your sunglasses, which are basically bright red orange granules, right? Can you appreciate the bright red orange granules here? They contain the major basic protein. This major basic protein is very important because it damages worms. When you think about the major basic protein as a design for parasites, right? Now we have some other proteins also like eosinophil peroxidase, eosinophil cationic protein, and eosinophil neurotoxin, right? These are some other proteins. Why do these increase? Why do the eosinophils increase? So we use a Pac-Man mnemonic for it, like in parasites, asthma, allergies, Churg straws, and chronic adrenal insufficiency and myeloproliferative disorders, and allergic disorders in neoplasms. Let me explain the Churg straws to you. All right, so what normally stimulates eosinophils, right? The major cytokine is interleukin 5 that is released from the Th2 cells. So the Th2 cells release this interleukin 5, and the interleukin 5 then tells the marrow to make more eosinophils and release them into the blood. So anything that increases Th2 type immune response or immunosuppression of eosinophils cause eosinophilia. We have something called as the Churg-Strauss syndrome. Now, this Churg-Strauss is basically a syndrome where you get eosinophilic granulomatous polyangiitis. What this basically means is this disease is basically an allergic atopic immune disorder combined with vasculitis. Let me stop here and show you what I'm talking about because it's getting really messy. Okay, so the Churg-Strauss syndrome is eosinophilic granulomatosis with polyangiitis. Eosinophilic granulomatosis with polyangiitis. Why do eosinophils increase? The disease is basically an allergic atopic immune disorder combined with vasculitis. Patients often have asthma, allergic rhinitis, nasal polyps, and eosinophilic tissue infiltration. The immune system becomes like heavily Th2 dominant. These Th2 cells produce interleukin 4, 5, and interleukin 13. The key one we're talking about here is the 5 one. The interleukin 5 goes and tells the bone marrow to make lots of eosinophils, and this leads to blood eosinophilia. Eosinophils infiltrate the lungs, skin, nerves, and vessels. A classic vignette would be a 40-year-old woman with severe asthma who develops peripheral neuropathy, which is basically foot drop, sinusitis, and marked eosinophilia. So you think about the Churg-Strauss syndrome, right? Again, another thing we studied here was why does eosinophilia happen in chronic adrenal insufficiency? This is basically the Addison's disease, right? The chronic adrenal insufficiency. Now, why do eosinophils increase here? This one is easy, right? Normally, the adrenal cortex makes cortisol. Cortisol suppresses eosinophils. It causes reduced eosinophil production, increased eosinophil destruction, movement of eosinophils out of the circulation. That is why people taking steroids have low eosinophil counts. But in adrenal insufficiency, the cortisol goes down. Since the cortisol goes down, there's loss of eosinophil suppression and eosinophils accumulate, which causes the eosinophilia. So a way to remember this would be that the steroids lower eosinophils and the steroids, the cortisol is lost here. So high cortisol leads to eosinophilia and low cortisol leads to eosinophilia, right? And then we have myeloproliferative disorders. These are basically your CML, polycythemia vera, and primary myelofibrosis. Why do eosinophils increase here? The problem is not allergy. The problem is the bone marrow itself. A mutated stem cell begins proliferating uncontrollably. You can't stop it. It's a cell gone havoc. Since eosinophils come from the myeloid linkage, the abnormal clone may overproduce them too. So you think of the stem cell mutation and the overactive marrow, and there are too many granulocytes, so there's too many eosinophils. In CML, you may see neutrophilia, basophilia, and eosinophilia all together because the whole series is expanding. Right? Let me just put it here because this is very important exam wise. So in CML, you may see neutrophilia, basophilia, and eosinophilia all together because the whole myeloid series is expanding, right? Okay, so childhood asthma. CDC shows 12% eosinophils. Why? Because eosinophils participate in allergic inflammation, right? Okay, that's our eosinophils. Let's move on to basophils. As we studied above, the basophils and mast cells are very similar, right? Let's study the basophils first. The basophil is basically the allergy cell in the blood. You think about basophils like circulating mast cells, not actually the same cell, but the same job, right? So the granules of basophils contain histamine and heparin. Histamine causes vasodilation, itching, swelling, and heparin is an anticoagulant, right? So I'm going to go again and like tell you these granules of basophils. Basophils basically contain histamine and heparin. Histamine is the one that causes vasodilation, itching, and swelling, your allergic symptoms, and heparin causes coagulation. Sorry, causes anticoagulation, so it causes bleeding. Now, classic question is this basophils are increased in CML. So the exam says basophilia, think about CML. I just told you that CML, all the mileages are increased, right? Then we move on to mast cells, right? So this is our mast cell. To remember which ones are basophils and which ones are mast cells, remember that the basophils stay in the blood, but the mast cells reside in the tissues. They are present in the skin, lungs, GI tract. The basophils stay in the blood, and mast cells stay in tissues. They're located in the skin, lungs, and GI tract. Their granules contain histamine, heparin, and tryptase, right? So they have IgE receptors. This is very important. Mast cells have Fc receptors for IgE. What basically this does is, okay, so first off, what is a mast cell? A mast cell is a tissue resident immune cell derived from the myeloid lineage, right? You'll find them in skin, in the respiratory mucosa and GI tract, and around blood vessels. Think of the mast cells as loaded hand grenades sitting in tissues waiting for an allergen. Now, how does this IgE interact with mast cells? The mast cell surface have these Fc epsilon receptors, right? These receptors bind the Fc portion of the IgE very tightly. So mast cells become coated with the IgE antibodies altogether. The mast cell can sit like this for weeks and nothing happens yet. What triggers the mast cell? What triggers the mast cell is the first exposure, like a peanut exposure. First exposure will lead to a Th2 response. The Th2 response are going to secrete interleukin 4, 5, 13. The more important ones are 4 and 13 for mast cells. Now, this leads to B cells switching to make IgE. When IgE is produced, the IgE binds to the mast cell very tightly. This is called sensitization, but there's no major allergic reaction yet. Now, what will happen is on the second exposure, this peanut binds IgE. The peanut enters again. The peanut protein binds to two adjacent IgE molecules. This is called cross-linking of IgE. So two IgE molecules bind to the peanut. This is the trigger. And the mast cell explodes with histamines mediators. This is called degranulation, right? Degranulation. Histamine is the fastest mediator. If the question comes, which is the fastest mediator, it's histamine. It's released within seconds from blood vessels and it causes vasodilation. Blood vessels widen and the result is redness in warmth. There's increased vascular permeability, there's swelling, edema, hives, which is urticaria, and anaphylaxis reaction. Airways, in the airways, the histamine causes bronchoconstriction. Airways become narrow. This leads to wheezing, asthma symptoms, and shortness of breath. In the nerves, histamine stimulates nerves to result in itching. This is why allergies are itchy. So what does heparin do? Heparin basically inhibits heparin. Mast cells store a lot of heparin. And heparin is an anticoagulant, so it inhibits clotting. Why? Because during inflammation, blood flow increases, and heparin helps keeps the blood moving through the inflamed area. So heparin is an anticoagulant released by the mast cells. What does the tryptase do? Tryptase is a protease enzyme. Think of it as a tissue remodeling enzyme. Functions are that it breaks extracellular proteins, amplifies the inflammation, and recruits other immune cells. Tryptase is measured in suspected anaphylaxis cases. High serum tryptase suggests mast cell degranulation. A patient collapses after a bee sting. You check the serum tryptase later, and this can support the diagnosis. So, what happens after all when IgE is cross-linked? You have histamine, heparin, and tryptase all leading to anaphylaxis, right? And what can you give to stop this? Cromolyn sodium basically prevents this mast cell degranulation. So we give cromolyn sodium sprays in allergic people. Now your dendritic cells are the most powerful antigen-presenting cells. Okay, they eat bacteria, process antigen, show antigen to T cells. Without the dendritic cells, T cells don't know who the enemy is, right? Now the marker of dendritic cells is the MHC class 2, right? So Langerhans cells in skin are dendritic cells and they contain Wernicke granules, tennis racket granules, right? So basically, they're the most powerful antigen presenting cells. They eat the bacteria, process the antigen, show antigen to T cells, right? They are basically, their marker is MHC class 2. I'm going to punch this here because this is very important. Remember, their marker is MHC class 2. Right? They eat bacteria, process the antigen, and show antigen to T cells. T cells don't know who the enemy is. The marker is MHC class 2. And the ganglion cell in skin are dendritic cells. They contain very big granules, like a tennis racket granule, right? Okay, let's do a bit of lymphocytes quickly. Lymphocytes are basically a broad category. They include your B cells, T cells, NK cells. Now, just to remind you that NK cells, when we talk about the NK cells, they are part of the innate immunity, like the innate immune response. They are not part of the adaptive immunity, right? So the NK cells are basically natural killer cells. They're part of the innate immunity. Their main job is to kill virus-infected cells and tumor cells through their perforins and granzymes. And the NK cells attack with the MHC1. Whenever some cells lack the MHC1s, many viruses decrease MHC1 to hide from CD8 T cells. NK cells recognize this and they kill them. They have two markers, the CD16 and CD56, right? They're not just markers used to identify NK cells, these are very important in both medicine and research. NK cell markers are CD16, CD56, and also CD3 negative, by the way. This helps to distinguish them from T cells, which are CD3 positive, because NK cells are CD3 negative. And the CD16 is the killing receptor. It's also known as the Fc gamma receptor 3, the CD16. Its main job is to find the Fc portion, bind to it of the IgG antibodies, and this allows the NK cells to perform. This allows the NK cells to perform antibody-dependent cellular cytotoxicity. So what this does is the antibody binds a cancer cell or a virus-infected cell. The CD16 on the NK cell recognizes the antibody, and the NK cell releases the perforin and granzymes, and this targets the cell that undergo apoptosis. So, an antibody tags the enemy. CD16 lets NK cell recognize that tag, right? So why is CD16 important clinically? Many modern cancer drugs depend on this ADCC. What is the ADCC? It is the antibody dependent cellular toxicity, cellular cytotoxicity, which basically is the mechanism through which NK cells attack, right? So now a lot of cancer drugs use this. Now, how does that make sense? Many modern cancer drugs depend on this ADCC. Examples are rituximab, trastuzumab, and cetuximab. All these three drugs, basically these antibodies coat tumor cells. And the NK cells then use these CD16s to recognize and kill those coated cells, right? So in oncology, CD16 is one reason therapeutic antibodies work. So what these three medicines, what they do is they coat the tumor cells with CD16. And then the natural killer cells find these CD16 cells and kill them. That's really cool, right? And then CD56 is also important. How? This is the NK cell identifier, right? And we call it the neural cell adhesion molecule. So CD56 is the NK cell identifier. We call it the neural cell adhesion molecule. Its exact role in NK cell biology is less important for exams than CD16, but this helps with cell-to-cell adhesion, cell-to-cell interactions, and migration within tissues. Okay, we now move on to the beta cells. Now, the function of beta cells is to produce antibodies, right? This is part of the maturation. They're made and maturing the bone marrow. So B for B cells, B for bone marrow. When activated, they become plasma cells, and plasma cells are basically antibodies, right? So they're activated to form plasma cells and memory cells. They can also act as antigen protecting cells. Why? Because they express the MHC2 receptor, right? So here we have some core B cell markers like CD19, CD20, CD21, CD22. So remember that a B cell is CD19, 20, 21, 22 positive. Now, why is that important for us? We use these markers, right? Where do we use these markers? So CD19 is the universal B cell marker. They're found on almost all B cells. So in flow cytometry, if you want to count B cells, you look for CD19. In medicine, many leukemias and lymphomas express the CD19, like ALL and diffuse large beta cell lymphoma. Okay, now move on to T cells. Okay, T cells basically mature in the bone marrow. They mature in the thymus, hence the T4 thymus, T4 T cells. You have some specific CD4 T cells, which are basically helper T cells. The CD4 ones are the helper T cells. They recognize the MHC2, and their function is to coordinate the immune response. Right? Just remember that this helper T cells, the ones that express CD4, recognize the MHC2. These are the ones that HIV infects, and the other ones are CD8 cells. The CD8 ones are the T cells, the cytotoxic T cells. They recognize the MHC1. This is very very important. It's a very highly tested in exams that the T cells that express the CD8 recognize them with C1 and is cytotoxic, and the ones that express CD4 recognize them with C2. So just remember, four twos are eight and eight ones are eight, so you have to get the eighth number right. Right? That's how first aid explains to you. Um, so the rule of eight will help you remember which ones express which ones. Then we move on to the plasma cells. Now the plasma cells are activated beta cells, B cells, sorry, that becomes plasma cells. Their function is to produce huge amounts of antibodies, right? So they, I told you that their chromatin looks like this clock phase chromatin in the eccentric nucleus, right? And multiple myeloma is a plasma cell dyscrasia. So disease that they cause is multiple myeloma. Remember that plasma cells, when B cells become plasma cells, they lose their CD20 marker. They gain the CD138 marker. So important pathology correlate is that plasma cell disorders like multiple myeloma are typically CD138 positive and CD20 negative, right? Let me end the video here.